Good evening. My name is Brian Robson. I'm the Executive Clinical Director here at Healthcare Improvement Scotland. And welcome to the fourth in our exciting lineup of QI Connect WebEx sessions for 2015. In fact, this is the 14th since the sessions began last year. This series came from a request from our national clinical leads here at Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field of improvement. They asked that we make the sessions short, accessible and recorded to allow access at a time that suited them. And to make it additionally accessible, we have arranged these sessions using WebEx. I'm going to hand over to Jennifer Graham just now to explain a little bit more about WebEx. Thank you very much. Good evening, Jennifer.
Thank you, Brian, and good evening, everyone. So just a couple of housekeeping slides to get started. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. If you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function, or press *0 on your telephone. On the right-hand side of your screen, you should be able to see a list of everyone who has joined the call. If you would like to make a comment or join the conversation using the chat function, if you could please select all participants or all attendees from the drop-down list circled in red on this slide, type your message and then send. So here's the fun, interactive part of the session. So we'd just like to find out where you're actually joining us from. And if you could just, using the toolbar at the top of the screen there, if you could just click on the blue arrow that's circled on the slide, and then just click on your location on the map there. Okay. I'm just going to now hand you over to Brian, who'll just tell you a bit more about the organisations linking in.
Great, thank you very much, folks. I see that Sanjeev has joined us from somewhere in the Irish Sea, but welcome to everyone from across the UK and beyond. We're delighted to say that QI Connect does seem to have been very attractive across the world. We now have more than 249 organisations that link into either the live episode or the recordings. And we're delighted that we have so many colleagues interested in this work and the conversations. When we first started the series, we had one slide showing the organisations that were joining us, and I'll tell you a bit more about those organisations in a moment. But before that, I'm going to ask you to use your blue arrows again. We're delighted with the reach of the organisation, the QI Connect series internationally. And we've been joined today by another new country. And the new country is Togo. Togo in Africa. And I would like you to show us with your blue arrow where the Togo flag is. The first one to get on the Togo flag wins a prize. So you're all currently on the Scottish flag. So well done, Jason Leach and others, for finding the Scottish flag. Can you find the Togo flag? Worth a shot, but not quite on the money. No hard lines, Ian. Well done, Fiona. Fiona Dane, well done. You've identified Togo in Africa. This is the latest country to join the series. Thank you very much, and I'm delighted to say that Fiona QI Connect mug will be winging its way to you after we finish tonight. So well done, Fiona. So our global reach is now reaching how many countries, Jennifer?
43 countries.
43 countries. So there you go. Thank you very much. And the organisations that I mentioned earlier, we're now looking at organisations we now take 5 or 6 slides to go through. So these are some of the organisations who are joining into the recording or live today. And we're always delighted to give a special shout out to our university colleagues who joined the call. We've always been very impressed with the interest from students and faculty and we now have more than 20 universities and higher education organisations joining the call. And a big shout out to the new joiners on this particular call. We're absolutely delighted to have Skimp General Practice New Zealand, the Arran Medical Group, and Elmwood Medical Practice, which is actually just down the road from where I live. So welcome Elmwood Medical Practice, as well as the other organisations you can see here on the screen. So welcome, and we do hope that you will join us for future calls. We're also delighted to say that the recording that we make of these calls are now available. We make them available on our website, and these recordings are used in classrooms and in organisations across the world. This is an image of Ko Awatea in Middlemore, North Island, New Zealand, listening to a recording of the QI Connect series last year. So we're delighted that these resources can be reused in other organisations. And again, just a shout out to the ISQA, the International Society for Quality in Healthcare. The ISQA Fellowship Programme features the QI Connect series as an approved resource within their fellowship programme. And also a shout out to the small but perfectly formed team we have here at Healthcare Improvement Scotland with Jennifer Graham, you heard from earlier, Carmen Forrest, who's responsible for the database and also for providing all of the CPD certificates to those who have joined after the call. And a big shout out to Ross Stewart, who's joined us in the studio today. Welcome, Ross. Thanks again for all your help in running the series. And a thank you to Jill Gillis. Jill is Improvement Advisor here at Healthcare Improvement Scotland and has been one of the leaders in the development of the Patient Safety Programme in primary care. And we'll hear from Jill a bit later on in the call when Jill puts the first question to our speaker tonight. And just before I introduce our speaker, just to remind you that we're very keen to reach out in the Twitter land, or the Twitter sphere, and if you use hashtag HISQIConnect, that would be great to be able to share what you're learning and encourage yet more people to make use of the resource and the discussion today. And I'll just emphasise again that the chat box is an opportunity to type in comments and indeed to type in questions. And I'll be collecting those comments and questions for our speaker at the end of his talk. And that brings us to tonight's speaker. I'm absolutely delighted to have Martin Marshall join us. Martin is a general practitioner, a professor of general practice. He was a previous Deputy Chief Medical Officer for England and latterly the Clinical Director for the Health Foundation. And now Martin has taken his quality improvement and general practice experience and is now the Professor of Healthcare Improvement at UCL London and a practicing GP in Newham in East London. And we're going to hear more from Martin now. Good evening, Martin.
Good evening, Brian, and good evening, Jennifer. Thank you very much indeed. I hope the sound is okay at your end.
It's very good, thank you.
Tremendous. Thank you to everybody for joining us this evening on this WebEx series. It's a real pleasure to be asked to speak on this series, and a particular delight, I have to say, to be asked to speak about my passion, which is general practice. Everyone, I guess, knows that general practice is important. In countries like the UK that have a strong traditional system of general practice, over 95% of the problems presented to our health service happen in general practice. That's over 1 million consultations per day. And we know that around about 90% of those are dealt with purely in general practice without any recourse to specialist services at all. So from a patient perspective, the health system essentially is general practice. It's as simple as that. We know from Barbara Starfield and other people's work that if you have a strong primary care system, then you get better outcomes for lower cost. So general practice really is the jewel in the crown. Therefore, it's surprising, I guess, that the quality improvement movement hasn't given an awful lot of attention to general practice. Most of the work that it's done, most of the ideas that it's developed, most of the methodologies that it's used have been established in general practice, and where they in the hospital sector, and where they have been moved to general practice, they tend just to have been picked up and dropped into the general practice sector. But general practice is very different in so many ways from the hospital sector. It's got a different philosophy, a different purpose, a different scale. It's more heterogeneous. It's got a different infrastructure. It's got fewer resources often to do quality improvement work. The staff have different capacities and capabilities, often less training in quality improvement. There's often less data that can be used more readily. So in many, many ways, general practice is quite different. And that's what I'm going to be talking about today. How different, and what are the implications of these differences for the way that we think about improvement and the way that we think about the use of improvement science. Let me start with a story. This is a story about a patient that I used to look after when I was a GP in Devon, in the southwest of England. For those of you who might not know where Devon is, it's way down in the southwest. It's a beautiful part of the country with wonderful beaches, beautiful villages and charming towns. And it was here that I looked after a lady who I will call Elizabeth. Elizabeth was in her mid-40s and she was clinically depressed. And she was depressed because she was involved in a emotionally abusive relationship with her husband. She was having a really tough time. I'd been looking after her for several years, and I'd been doing my best as a GP to try to help her, to show her potential solutions to the problems that she was in. But she turned down almost everything that I offered until eventually, after about 5 or 6 years, I managed to persuade her to take some antidepressants, some Prozac, in fact. And her response to those Prozac was almost as if it was straight out of a textbook. It was remarkable. So for the first couple of weeks after I gave her the prescription, she complained of some side effects, some dry mouth, feeling slightly fuzzy in her head. After about 3 weeks, she said she was just starting to feel a little bit better. After 6 weeks, she said she was feeling enormously better and her relationship with her husband was starting to get better. After about 2.5 months, she said she was pretty well back to normal and her relationship with her husband was just brilliant. After 9 months, we agreed to stop the medication and her mood stayed the same and her marriage stayed the same. It was a wonderful story. That should have been the end, I think, of a very happy story, except about 18 months later, Elizabeth came back to see me with a slightly sheepish smile on her face. And she said, "Dr. Marshall, I've got a confession." She said, "I never actually took those antidepressants that you prescribed for me." She said, "The way I figured it wasn't my problem, it was my husband's problem. He was the one who was so miserable all the time and making my life a misery. So I took my antidepressants and I put them in his morning coffee every morning. For the first couple of weeks, he complained of a few side effects, but after about 3 weeks, he was looking a little bit better, and after 6 weeks, he was much better. After 2.5 months, he was brilliant, and now we've got the best relationship ever." It was a wonderful story. Elizabeth's story makes me think about the nature of general practice. It's had a big influence on the way that I think about what I do as a general practitioner. It's made me realise that things that are present in general practice are rarely simple. They rarely come neatly packaged, or if they are packaged, when you unwrap them, they're always much more complicated than they appear to be. This is just one of many interactions with patients I've had that make me question, what is general practice? What is quality in general practice? And how do we improve it? More challengingly, I think it makes me question, what is the quality improvement movement for? And is the quality improvement movement, and indeed improvement science, doing general practice and other less technical specialties a favour? And this is what I'm going to focus on in this presentation. I'm going to do something which is slightly dangerous as well, because I'm going to present a problem without really presenting a solution to you, or at least I'm not entirely clear myself what the solution is. So a good outcome for me from this session is not the usual outcome from a quality improvement session, which is what am I going to do differently tomorrow in my workplace. But what I simply want to do is just provoke you to think about how relevant is improvement science to what we do in general practice. How might we think about and reward quality in a more comprehensive way than we do at the moment? I'm not going to say for 1 second that there isn't an awful lot of systematic quality improvement, the application of good quality improvement in general practice. And I want to give you some examples from quality improvement projects that I've been involved in East London, where I work as a general practitioner. The first example is an example from the field of domestic violence. Domestic violence is very prevalent, particularly where I work in East London. And we know about 15% of the people who are exposed to domestic violence have that recognised in their notes. So the vast majority of people, domestic violence is both poorly diagnosed and poorly treated. This is a quality improvement project done by Jean Fader and colleagues in East London and also in Bristol, in which they introduced an educational intervention using a multidisciplinary team. They introduced that intervention to people who are victims of domestic violence, and they evaluated the outcomes of that work using, for quality improvement, in the quality improvement world, a very robust design, and actually an experimental design. And what they demonstrated as a consequence of this intervention was a 3-fold increase in identification rate of domestic violence and a 22-fold increase in referral rate. So it was a superb example of systematic quality improvement in a general practice setting. The second example looks at COPD, chronic obstructive pulmonary disease, also a very common condition, also underdiagnosed and also poorly treated. Particularly common, I have to say again, in the kind of people that we look after in East London. Here what we did was use a rather more complex intervention which had some technical components to it and some social components to it. We implemented it across over 190 practices in East London, and we demonstrated some significant improvements in a range of different outcomes. And this paper that we published in the British Journal of General Practice demonstrated some of the challenges of doing this kind of large-scale quality improvement work in a socio-economically deprived community. So another example of a good systematic quality improvement project. And the final example comes from some colleagues, John Robson and Sally Hull and their team, based at Queen Mary's University in London, where over 15 years or more they've done some really stunning work creating practice networks, feeding data back to practices, using practice facilitators in order to demonstrate significant improvements in adherence to clinical processes. Indeed, parts of East London have got some of the highest success rates for things like QOF targets of anywhere in the country, despite the challenges of the community that they serve. What's common across these 3 projects that I've described to you? Well, 2 things, I think. First of all, they all focus on the measurable aspects of care. And indeed, that's entirely compatible with the mantras that we use in the quality improvement world. If you can't measure it, you can't improve it. Or as my great friend and colleague Jason, who I think is on the line, said in a recent tweet, just measure it. If it gets better, carry on measuring it. If it doesn't, measure something else. Now, I can't use Jason's beautiful, broad Scottish accent, but those of you who know Jason will just be able to hear him saying that in a not too menacing way, of course. The second thing that these 3 examples demonstrates is that we're focusing in quality improvement on areas where there's a right answer or a wrong answer. So identifying victims of domestic violence is a good thing to do. Failing to identify them is a bad thing to do. Following guidelines for COPD care is a good thing to do. Ignoring those guidelines is a bad thing to do. This is the simple area of clinical practice, if you like. And the approach that we use in quality improvement is simple, it's intuitive, it's compelling, but there is a problem. And this is the problem. The evidence tells us that about 60% of the problems that patients present in general practice cannot be understood in terms of recognised disease processes, and the majority of problems presenting to general practitioners have no single correct solution. This is a big challenge to us in general practice. General practice is messy. It's difficult territory. It's not territory where you can rationally break things down into their component parts and start measuring them and think you're reflecting the nature of the clinical care that you're providing. I'm not a great lover of fly-on-the-wall documentaries, particularly not ones relating to health, but I've been particularly taken with this documentary on one of the British channels called GPs Behind Closed Doors. It's a most sympathetic portrayal of both people who use GP services, the vagaries of the human condition, the ways in which they interact with their general practitioners and with the general practitioners themselves. It's a beautiful program in many, many ways. And it highlights to me some of the descriptions that some of the great old people of general practice have said about the nature of general practice. Iona Heath described the general practitioner's job as to witness people's suffering. And Marshall Marinka rather prosaically said, general practice is a specialty of diseases without names. Much of what GPs do is deal with uncertainty. We manage paradox. We operate in areas where there isn't one good, there's competing goods. We have to understand and manage contradictions. We have to deal with messiness. We have to deal with the inherent tensions that are part of healthcare and indeed part of life. General practitioners are what I've described in previous presentations as essentially boundary specialists. So let's look at some of the boundary problems for Elizabeth's presentation. And here we have two views of the world. We have Elizabeth's view of the world on one side, and we have what you might call a conventional doctor's view of the world on the other. So Elizabeth presented a problem, an illness, if you like, and that was her unhappy relationship. I did what doctors are supposed to do, which is to turn that illness into a disease which I gave a name, depression. I then did also what doctors are supposed to do, which is, having given a label to that disease, I needed to treat it. So I provided professional care. I prescribed an antidepressant for her. And Elizabeth responded by doing what you'd expect a sensible patient to do. She self-cared, and she treated the person who had the problem rather than the person who didn't have the problem. The interesting issue here is that all the drivers in the system, all the incentives in the system, encourage me to operate on the right-hand side of this diagram. Indeed, quality improvement methods, with their focus on measurement, encourage me to operate on the right-hand side of the diagram. But actually, my function as a GP is to act in this boundary area, this area between Elizabeth's view of the world and between my view of the world. And that is the complicated area to work in. Let me give you another example, this time from my current practice. You can see from the pictures here that I've gone up in the world. I now work in a vibrant inner city area in East London, very multicultural, very socioeconomically deprived. It's a fascinating area to work, and I feel privileged to work there. And here I'm looking after a gentleman who I'll call Mohamed. Mohamed is in his early 30s. He's married with 2 children. He's from Iraq. He's been in the UK for about 12 years now. And as you can see, Mohamed is obese, and he has very, very poorly controlled diabetes. Indeed, he's one of my biggest clinical challenges at the moment, just trying to control his diabetes. So the other day, I asked him to come to see me, and I decided I'd sit down and I'd have a basic conversation about his diet. And I said, Mohamed, what's the food like that you eat? And Mohamed said, Dr. Marshall, very nice food, very, very nice food. So I said, what kind of food do you eat? And he said, well, here in the fried chicken shops. I go to the fried chicken shops twice a day, and I have 2 big meals of fried chicken and chips. And it's very nice food. I'm very happy with it. And I said to Mohamed, well, do you eat anything else? Do you go down to the local market? There's a beautiful market in East Town with wonderful green vegetables. And Mohamed explained his social situation to me. He said, Dr. Marshall, I live in a flat with 2 bedrooms and 17 other people, mostly friends and family. We don't have any kitchen, and we hot bed. We've only got 4 beds, so we have 4 hours in bed, and we have the rest of the time out. And I don't like hanging around with all the other people in the flat, so I go down to the fried chicken shop. The fried chicken shop is where I find peace, it's where I socialise with my friends, and it's where I eat lots of food, which is incredibly cheap, less than £4 a day. So let's look at Mohamed's boundary problem here. Mohamed's view of the world. Well, first of all, did he present an illness? No, he didn't. I asked him to come to see me. As far as he was concerned, he was really well. In fact, Mohamed is extremely happy with life because the lot that he has living in East London is far better than the lot that he had when he lived in Iraq. So no illness from Mohamed's point of view. What did I do? Nevertheless, I gave it a label, a disease, poor diabetes control. What did I do? Well, I could have, and I did, and I do, manage his condition in a conventional medical way, but I also want to take a public health perspective. What I want to do is to work with the local borough to close these damn chicken shops. They're a nuisance. They're a public health nuisance. And yet, from Mohamed's point of view, these chicken shops meet his individual need. They provide affordable food, a place to socialise, a place to find peace. So again, all the incentives in the system are encouraging my behaviours to go over to the right-hand side. The right-hand side is where we focus as quality improvers. And yet my role, I think, as a GP, is to act as a boundary specialist, to operate in the centre between these two different views of the world. This challenge of the kind of high, hard ground where rational thinking is reasonable on one side and the swampy lowlands of frontline care on the other is beautifully described by Donald Schoen in his book, The Reflective Practitioner. If you haven't read it, I really recommend you do so because it's a tremendous book. And what Schoen says is in the varied topography of professional practice, there's a high, hard ground overlooking a swamp. On the high ground, manageable problems lend themselves to solution through the use of research-based theory and technique. In the swampy lowlands, problems are messy and confusing and incapable of technical solution. The practitioner is confronted with a choice. Shall he remain on the high ground where he can solve relatively unimportant problems according to his standards of rigour, or shall he descend to the swamp of important problems where he cannot be rigorous in any way he knows how to describe? So much of general practice is in those swampy lowlands. Of course, we need both. We need systematic, data-driven, rational quality improvement, but we also need to recognise there's something else going on in the world. And there's lots and lots of examples of these boundary challenges. Screening is a superb example. Of course, screening is a good thing to do if it satisfies the traditional criteria for screening. But sometimes screening can go too far. Huxley made this wonderful comment: medical science has made such tremendous progress, there's hardly a healthy human being left. And if you look at things like the change in diagnostic criteria for pre-diabetes, produced by the American Medical Association, just tinkering with diagnostic criteria has suddenly increased the prevalence of this condition, if you want to call it that, by threefold. The National Institute for Clinical Excellence in the UK has changed the threshold for treatment with cholesterol-lowering drugs, and as a consequence, if we follow it, we'll have 25% of the adult population in the UK receiving lipid-lowering drugs. Does this seem right? What is the GP's role in managing these different forms of evidence, because there is evidence for and against screening, even in these areas? The GP's role, it seems to me, is to try to achieve a balance between these differing experts' views. If you like, to balance the disease-mongering advocates on one side with the disease-denying skeptics on the other. And that's a challenging role. And there's many other different boundary activities that GPs have to participate in and lead. The boundary between self-care and professional care, the boundary between individual care and collective care or population care. So this begs the question, I think, does this disconnect between the simple elements of improvement and clinical practice that we focused on largely in the quality improvement world and the complex really matter? After all, of course, we must focus on technical process of care. We must get them better. That's what we're here for as doctors and as health professionals, because it improves health and it improves lives. Surely I should be lauding the quality improvement movement rather than criticising it. Maybe I should just be accepting that measurement is a partial activity and that's the way it is. But the problem is that social economists like Bruno Frey have demonstrated to us convincingly that if you focus on one area, then that crowds out other areas of professional practice. And this has been known for a long time, and some really great work done by my colleague Martin Rowland, previously from Manchester, now in Cambridge, demonstrated the unintended consequences of the financial incentives that we use in the GP contract in the UK. Here he demonstrated that if you measure and record and reward clinical processes of care, then in almost all cases they'll improve over a period of time. But the things that you aren't measuring, in this case continuity of care, will either stay the same or get worse. So it does matter, I think. If I look at my professional practice over the last 25 years, it seems to me that the complexity of what I'm seeing is increasing all the time, at the same time as the incentives, the rewards, the performance management, the regulatory drivers, and indeed the quality improvement movement are forcing us to focus on the simple, technical, instrumental This doesn't seem to be good for patients. It doesn't seem to be good for GPs as well. Indeed, I think often for GPs, this sophisticated role of the boundary specialist is often felt not to be valued or even understood by other people, particularly by policymakers. And there's nothing more demotivating than feeling unrecognised or undervalued. And I wonder whether this is one of the reasons, along with the workload, of course, for why so many clinicians have poor morale at the moment. Is there a solution to this problem? I could just imagine some of my academic colleagues salivating at the prospect of being able to develop measures of some of these complex areas of activity to allow us quality improvers then just to get on with the job with these new measures, which allow us to measure and record and feedback. But that, to me, I think, would miss the point. Rationalising the less rational is probably easy to do if you're clever enough, but it's often not very helpful. So what I'd like to do is introduce 4 solutions, fairly broad solutions as I described, which I think might help us to think differently about the nature of quality in general practice. And the first one is a really simple one. We simply need to acknowledge that general practitioners have this wider role that goes beyond the simple reductionist activities that we do and we want to do and we have to do. You wouldn't have thought that would be very difficult, but it does seem to be remarkably difficult to recognise, acknowledge and value these activities in the culture that we have in the health sector. That isn't the case in other sectors. If you look at Charles Hamby's writing, a management consultant and one of the great commentators and authors in this field, he described that in the business world, most decisions that we make are not between right and wrong, but between right and right. And that's what I'm describing in the health sector. Niels Bohr, the Danish physicist in the field of physics, said we'll never understand anything until we found some contradiction. And Ivan Tillich, the German philosopher, said the boundary is the best place for acquiring care. So perhaps we just need to recognise and value and find ways of understanding the fact that GPs have this complex boundary role to play. The second solution that I want to present is that we need to understand and champion new change models. And in this respect, I think we're starting to see change. Some people are saying that the society that we live in, with its focus on measurement, its focus on rationality, that's just the way things are going. There's nothing we can do about it. But if you look particularly at the impact of social media on the way that we're working, increasingly we're seeing some quite significant changes, which I think are in line with what I'm discussing for general practice. So we're seeing a shift from the exercise of power through hierarchy within organisations to the exercise of influence through close connections. We're seeing a shift from the business mantras of missions and visions to much more of a focus on shared purpose. We're seeing a shift from people making sense by using rational argument to making sense using emotional connection. Marketeers have told us for a long period of time that emotional connection is what makes a difference. We're seeing a shift from leadership-driven innovation on one side through to a much more stronger focus on viral creativity. We're seeing a shift from tried and tested change, searching for hard evidence for everything that we do, to a stronger focus on experiential co-creation of knowledge. And finally, we're seeing a shift from a transactions approach towards change to a relational approach towards change. So we're seeing a range of shifts in a range of different ways, which I think are starting to recognise the complexities of what we're doing, and not only recognise but also value those complexities as well. The third solution, which I think is important, is that we need to be focusing far more on the education and training needs of all of us as practitioners, as health professionals, as people who work in the health sector, but particularly the next generation. We need to be helping people to understand that they're only half trained at the moment. They're trained in the content knowledge, they're increasingly being trained in the technical skills that they require to be good clinicians, but what they're not trained is in the skills of negotiation, for example. What we need is more practical wisdom, or as Aristotle called it, phronesis, in our educational curricula. And there's plenty of places that we can go to to learn about negotiation. In the business world, where negotiation is a massive issue, which is taught all the time. In the diplomatic world, where it's also taught a lot. So there are places that we can go to. We need to build on the teaching of knowledge and skills in order to emphasise this concept of phronesis or practical wisdom to allow us to work more effectively at the boundary. And then finally, my fourth solution is, of course, that we need to carry out more research into this boundary role. The fact that it's complex, the fact that it's difficult, doesn't mean that we can't understand it more effectively and then perhaps practice it more effectively as a consequence. So there's lots of research questions that we could be asking ourselves and lots of different methodologies that we could use to try to address those. So what are the most important dimensions of the boundary roles? What are the facilitators experienced by practitioners in exercising this role? Why do some practitioners do it well? And perhaps more importantly, what are the barriers that we experience in trying to exercise a role? What do effective boundary practitioners do? Let's do some case studies of people who are really good at managing this complexity. Some really interesting video work that could be done there of particularly sophisticated practitioners. What are the most effective ways of learning about the boundary role? And what do patients think of the boundary role? So lots of questions that I think we need to find answers to. So in summary, in this presentation, I've presented a challenge to the quality improvement movement. I think it's currently preoccupied with the easy elements of care, transferring the more technical areas of expertise and methodologies and processes that we've used in the hospital sector into general practice and just assuming that they'll be relevant and assuming that they'll work. I think we need to progress beyond the traditional dimensions of quality in order to reflect the complexity of clinical care. What I've suggested is that general practice needs to be able to demonstrate measurable improvements. Of course it does. I'm not trying to polarise this argument in an unhelpful way. But that isn't enough on its own. I've suggested that we need, one of the most important roles of a general practitioner is to manage the inherent tensions, the paradoxes, and the competing demands that they experience in their daily jobs, and this is the boundary role. And I've suggested that the boundary role needs to be better understood, better practiced and better valued if general practice is to survive. And indeed, I'd also say that the science of improvement needs to become more sophisticated to recognise these activities if it is to have the maximum impact that it can and should have on the way that we provide high quality and safe care for the patients that we look after. Thank you very much for listening.
Thank you very much, Martin. What a deep and broad presentation. Thank you very much, and thanks very much everyone for the chat. We'll come back to the chat and the questions just in a moment. But let's welcome in Jill Gillis. Welcome, Jill.
Hello, can everyone hear me okay?
We can. Thank you very much. Jill, you're going to be asking Martin the first question.
Yeah, Martin, thanks very much for that really thought-provoking, probably a number of questions here and really try and pull it into one. I mean, very much recognised what you were saying about a number of the unintended consequences on focusing on the simple technical elements. And we do that in many ways with the safety programme in primary care in Scotland, but we've also tried to explore some of the more challenging areas, and we do have a safety climate survey that we really try and explore what that culture within that practice setting looks like. But that's very much focused on the practice, and I think for me the sort of thought-provoking element was really very much about how do we get then into those boundary conversations. And our mental health safety programme has a safety climate survey that's with the patients, and I wonder, are we ready in general practice to introduce such a tool that we explore those boundaries and have a joint tool that works looking at that culture with the practice and patients within that locality, and potentially use some sort of tool to co-create values for that locality to focus on, and those would be the areas of improvement and quality that locality would have jointly co-created.
Yeah, thank you. I think that's a really good suggestion, because in many ways culture and climate, if you like, a more superficial manifestation of culture, is in that middle ground, isn't it? So it can be measured, but it is a complex representation of the context that we work in. I suppose I did a little work some years ago on measuring culture and measuring climate, and we did a review of the various instruments, and I suppose I'm a little bit suspicious about some of the quantitative measures of climate. I'm a little bit suspicious about their validity. I don't think it's as good as it could be. And it was as a consequence of that we developed an assessment tool which wasn't a measurement tool of safety culture, which is called the Manchester Patient Safety Framework. And that was used primarily as a way of teams working together in order to gain an insight into their orientation towards safety. And that seemed to me to work very effectively. But I think you're right, that if we're looking for something that's middle ground, something that's somewhere towards representing the complexity of what we do, then the safety culture and safety climate would be a great place to start.
Okay, thank you.
Thanks very much, Joe, and thanks for that, Martin. Now, a fair amount of chat here, Martin. People were particularly taken with the idea of the working in the boundaries and the boundary role, thanks to Michelle Watt, Associate Medical Director in Primary Care at NHS Tayside, for commenting in the chat there. We've also got David Hogg, GP from Arran. David has been commenting on surrogate markers of good care. Does Martin have any suggestions on what he would like to see as appropriate markers of quality care in general practice?
And is David there, and is he able to answer his own question? Because it's a really good question.
So he's not able to answer his own question. He's just available in type at the moment.
Oh, what a shame! What a shame. So again, it's an interesting question because do we want surrogate markers? I suggested earlier a range of solutions to addressing this challenge, none of which were about measures. So if by markers David means a measure, then maybe, but possibly not from my perspective. If by markers he means something softer, something that reflects the complexity of what we do, then I think, yes, that would be good. Now, wouldn't it be interesting to devise a set of soft markers or things that represent the kind of problems that I've described with Elizabeth, possibly, although she's an outlier, of course, but particularly with Mohamed. I see Mohameds every single day of the week in my practice. So many of these people that have really complex problems where my job is not to behave like a conventional doctor. I could think of some surrogate markers. Wouldn't time in a consultation be an interesting one? I mean, that could be quite a fascinating one, the length of time taken. There might well be markers around narratives about patient experience after they've had interactions, perhaps multiple interactions with clinicians. So I think there's a range of different markers we could think about, and I'd rather focus on the softer ones than I would focus on the measurable ones, which inevitably are likely to lack validity in this kind of complex area.
Yeah, thanks very much, Martin, and thanks, David, for that question. I see Jason Leach has been active in the chat, and he was suggesting, how about this as a quality marker? Did you get the care you wanted and needed when you wanted and needed it? Neat.
Yeah, I'd like to ask Mohamed that question and see what his response would be. And I genuinely don't know. I've maintained a relationship with him. I think I've probably maintained and building a stronger relationship with him by not challenging him too hard, by not giving him a hard time for his obesity or his terrible diet. Perhaps if I said to Mohamed, are you content with what I'm doing for you, that I might get a positive response, or I might not. I really don't know. I should try it, shouldn't I?
We could try it in the very next patient. You're right. Michelle Watt's come in again, Associate Medical Director, Primary Care in NHS Tayside, and she was wondering about what a measure for GP satisfaction might look like, and whether that's important, asks Eloise Johnson.
So is this a measure of GPs' satisfaction themselves or satisfaction in GP consultation? Sorry, I assume the former.
Yeah, it's a good question. Perhaps either. So let's take how satisfied patients are with GPs, their engagement with general practice, and then perhaps a follow-up. Are GPs, how do you raise the joy at work or the satisfaction of the GP's role?
Okay. Well, I think the first one is easy because we've got no shortage of pretty sophisticated measures developed in a range of different countries. You've got many that you use in Scotland. We've got some great ones that we use in England. John Campbell down at Exeter has done a lot of work in this field. There's the CAP surveys, which have been developed over 20 years or more in the United States. So I think we've got lots of measures of patient satisfaction with their doctors. The other question is the much more challenging and much more interesting one. I, for one, have got a bit fed up of filling out BMA surveys that ask me whether I'm satisfied, what my morale is like. The surveys always feel a little bit leading and not very meaningful. I'd love to develop a survey of clinicians' satisfaction with their workload. I've got a sneaking, with their job in general, and their workload would be an important component. I've got a sneaking component idea that at the moment in the NHS, many people would express their concerns about the direction of travel, and a lot of that is about workload. I think the 10-minute consultation is a disaster. I think we need to be thinking much more creatively about how we use time in general practice, and 10 minutes simply isn't enough. I remember reading a saying from the 1920s, a very famous physician who described general practice as perfunctory work by perfunctory people. It was a terrible description, but to a certain extent there's a feeling of truth about it when you're rattling through your 75th patient of the day. What can you possibly do in terms of providing high quality care? So I think that we could very helpfully develop some interesting assessments of what general practitioners mean, and I'd like to think that it would start getting at this issue of the boundary role, because I don't think we've really thought about it or surfaced it in a way that I'm trying to do in the work that I'm doing at the moment. And I'd love to be able to find a way of getting at it and understanding it more comprehensively than I do at the moment. My understanding is very superficial at the moment.
It sounds as though, and looks as though from the chat, as though everyone's trying to get deeper into that understanding. So thanks very much to Denise Eddy, Occupational Therapy Lead in Mental Health at NHS Highland, and also Elaine Johnson, Clinical Effectiveness Facilitator at NHS Lothian, for their comments. And Denise particularly points to, she's looking at using an approach called CoreNet, which allows patients to evaluate their therapeutic relationship after each session, as well as scoring risk in terms of their mental health and rating individual goals. So she's describing something there that could be a good all-round measure. I wonder, we've got a comment here and a question from Andrew Manchip.
Comment on that, Brian, sorry, very quickly.
Oh, sure.
Because I agree. I think that's, those kind of measures are really interesting. So the therapeutic relationship measures, there are a few. They were being developed about 15, 20 years ago and then seemed to get lost. So I'm delighted to hear they're coming back again. Stuart Mercer's work on empathy is fascinating. I've forgotten the name. John Howie's work, of course, from Edinburgh, did some superb work on enablement, which to a certain extent starts to get at some of these issues. And I think all of these are efforts by thoughtful GPs or GP academics to try to find a way of representing what they do. So many people are struggling with this problem. We've got a real opportunity to try and bring those people together, I think, now.
Yeah. Thanks, Martin, and thanks also to Keith Moffat, academic GP, who's highlighted the importance and the increasing complexity around multimorbidity. Thanks for the link to the NICE work on that. Martin, Andrew Manchip is a medical reviewer and forensic doctor here at Healthcare Improvement Scotland, previously a GP in NHS Lanarkshire. And Andrew's highlighting that with the increasing reliance on salaried or sessional and part-time GPs, continuity of care may become a higher challenge with more boundaries and more boundary roles. Your thoughts on that?
Yeah, well, he's touched a really delicate nerve for me because I'm a very part-time GP now. Indeed, I have been for 15 years. So I do no more than a day a week of clinical practice. So am I in that category? Well, I am. I certainly feel a disadvantage not being able to develop a substantive relationship over time with many of my patients. But also, having been a GP for 27, 28 years now, I think I've got that kind of sixth sense, that wisdom that comes with being able to understand people more quickly than I could 10 or 20 years ago. So I don't think it's just about relationships. I think it's about sophisticated consulting skills. It's about empathy. It's about emotional intelligence. It's about many factors. So I've got no doubt that part-time general practice is an issue, but I don't think it has to be a major one. In terms of salary status, who knows? Maybe that's just a measure of turnover. It certainly, in my mind, isn't a measure of any lack of commitment. So sometimes principals who have major weighty business matters on their mind at the same time as providing clinical care might struggle to provide the kind of personalised care that we're talking about more than salary doctors do. Who knows?
Thanks very much. And Jason Leach, the Clinical Director for the NHS in Scotland, of course. Jason's coming back in with a bit of a challenge, and he's saying, is general practice special? Surely acute medicine, care of the elderly, emergency department teams also work in boundaries.
Yeah, it's a good challenge, Jason. I think everybody who works in healthcare as health professionals do work at boundaries to a greater or lesser extent. So this is a question of degree, I think. I think the boundaries that GPs have to experience as generalists and as psychosocially orientated medics are that bit more significant in scale and in complexity than if you were a cardiologist putting stents in, or dare I say, a dentist removing teeth. There's something about the less technical specialties in which I think the boundary roles are more significant. I think probably psychiatrists, I think probably paediatricians amongst the specialists are the ones who are most boundary orientated, but I can't think of anybody whose principal job is to be a boundary specialist, which I think is the case for a GP.
Thanks, Martin. We've got a bit of a conversation going here with David Hogg from GP from Arran, and also from Libby Keck, who's a program manager at the Health Foundation, and they're agreeing that there's a role for narrative medicine. What's your view on or experience of narrative medicine in managing the boundary role in general practice? Yeah,
I think they've hit the nail on the head, and I'm not a specialist in the field. I love the work that people like Trish Greenhow and others have done in this field. I think that probably is. I think stories is such important data in this kind of territory where measures can't necessarily reach. So I think it's really important.
Great. And Sanjeev Chauhan, a Scottish Patient Safety Fellow and consultant in NHS Lanarkshire, he is again saying he wonders whether more attention to boundaries would improve care in hospital also, and perhaps an over-focus on managing patients' disease, but not always their ability to live their lives. So it sounds as though there's some currency around this in the hospital setting as well.
Yeah, I think there is, and I think there's a resurgence of the generalist, isn't there? Not just in the community, not just general practitioners, but generalist specialists. And to a certain extent is driven by the economics. Generalist specialists are easier to employ if you're running rotas. But actually, there's a real opportunity here because generalism reconnects doctors with their roots of being whole person physicians. It's specialism that's taken us down very tight lines, and which in many ways has resulted in it being increasingly difficult for some doctors to connect with their patients.
Yeah, Thanks very much, Martin. And we have a question here, a comment from Rachel Hardy, who is a consultant in public health medicine at NHS Lothian and also works at the University of Edinburgh. Rachel says, it would be interesting to explore how the house of care approach impacts on the boundary. How does a more enabled, informed and prepared patient affect the boundary with a more collaboratively minded professional? Looking at it from that angle. Thoughts, Martin?
Yeah, great question. I haven't really given very much thought to the boundary role from the patient perspective, but I think we need to do so, and that would be part of the kind of research program that we could develop in this field. If anybody's out there and wants to do it, I think it's really important. I don't think patients look for simplicity in a way that doctors try to persuade them they should. I think patients recognise the complexity of what we do and they respect it. I think often that's implicit, but I don't think it's an accident that GPs come out as the most respected of health professionals, indeed of many different work groups, because there's something about our ability to deal with that complexity which is highly valued by patients. My concern is it's not highly valued by the system and it's not highly valued by policymakers, and perhaps actually we're at fault for that because we haven't gone out of our way to describe it.
Thank you very much, Martin. There are so many good comments and very thoughtful comments in the chat box. Thank you very much to Michelle Watt again for highlighting to us the NUCA model, and also Gordon Cowan, who is a latest cohort of SPSP fellow and a consultant anaesthetist in NHS Lothian, that leaves us with a good thought to end on. He supposes that the very essence of person-centred care is balancing the different competing demands at the boundary. A nice place to end.
Nice place to end.
Yeah, Martin, thank you so much indeed for your thoughtful and thought-provoking talk this evening. Just before we leave, Jennifer, you have something else to say.
Yes, thanks, Brian. So I just want to flag to your next QI Connect session, which is with Professor Mary Dixon-Woods on the 28th of May 2015. I think Brian's just going to tell you a little bit about Mary's biog and just what you can expect from the session.
Yeah, thanks very much, Jennifer. So we're absolutely delighted to have Mary join us. Mary is a Professor of Medical Sociology and Director of the Sapphire Group at the University of Leicester and Deputy Editor-in-Chief at the BMJ. She is arguably one of the world's most prolific and meaningful researchers in the field of quality improvement, and has brought the medical sociology to the fore in the quality improvement movement internationally. We're absolutely delighted to have Mary on the call next month. And here we have the exciting lineup. We heard wonderful things about the 20,000 Days programme from David Grayson. We heard about Beth Lilia's approach in mobilising society to improve care in Denmark, and the wonderful outline of the role of health IT or the risks around health IT from Bob Wachter last month. And this month we've heard from Martin about the need for acknowledging the wider role of the general practitioner, championing new change models, building capacity and capability in boundary challenges, and carrying out more research into the boundary role. You can see the lineup for the rest of the year, and just a big thank you to everyone. Thanks for tweeting this evening. Big thank you to Jill Gillis for her thoughtful comment to Martin, and I look forward to joining you again next month. Thank you all, and good evening.